Good morning, everyone. It is my honor and pleasure to introduce today's Grand Round speaker. Dr. Jennifer Graves is a professor of neurosciences and is director of the Neuroimmunology Research Program at the University of California, San Diego. She attended UT Southwestern for medical school, where she earned an MD and PhD in molecular biophysics. She trained in neurology at the University of Pennsylvania, then completed 2 fellowships, one in neuro-ophthalmology at Penn, and another in multiple sclerosis and clinical research methods at UCSF. Her current research focuses on the role of biological aging in MS phenotype, in particular progressive disease. Without further ado, I heartily welcome Dr. Graves.
Thank you so much for the invitation to join you all this morning and to be able to talk about aging in multiple sclerosis. So I don't have any disclosures directly related to the content of today's talk. As an overview, I will be presenting you with the concept that disease expression or phenotype in MS is related to characteristics of the host who lives with the disease. And the most important of these host characteristics is chronological age. And I'll be summarizing patterns for you related to chronological age in MS, including relapses and non-relapse related disability accumulation. I'll be distinguishing for you the differences between a biological definition of age and a chronological definition of age, and provide you with evidence that progressive MS is an aging-related disease, and that in patients living with MS, they're facing both the effects of normal aging that we all face, as well as possible accelerated aging from the MS disease process itself. And we'll conclude with some multidisciplinary therapeutic considerations for how to take care of this population of patients aging with MS. So just some basics about age and epidemiology and multiple sclerosis. Keep in mind there is pediatric MS, and I have the honor and opportunity to take care of both children and adults living with the disease. Pediatric onset occurs in about 5% of MS cases. The mean onset of relapsing disease is around 30 years of age, but the mean age of onset for the neurodegenerative treatment refractory primary and secondary progressive forms of MS is around 45 years of age. And with new epidemiologic data, the prevalence of MS, the mean age is shifting. With our improved care and treatment options, the mean age of those currently living with MS has shifted such that 46% of people with this disease will be over 55. So as a reminder, MS has a highly varied phenotype. There's a spectrum of severity from those who have silent MRI findings to those with more malignant and aggressive forms of MS. And this classic figure on the right-hand side is how we've all learned to think about multiple sclerosis. The dark black line in the middle is clinical disability. And the first upward deflection of that disability is the first attack of MS. The arrows on the bottom are new T2 lesions that are forming. And the dotted line at the top is brain volume over time. 85% of adults present with the relapsing form of the disease in the center of the figure, and about 10 to 15% start in a progressive form of the disease on the far right-hand side, where there's slow, steady accumulation of disability without any remittance. But in children, 99%, or I would argue even 100%, present with the relapsing form of disease. And when I was first studying as a neurology resident and learning about MS, my assumption was always that the time variable on the x-axis was disease duration, that this is a process and a disease course that all MS patients go through. But as I'll show you throughout this talk, it's really probably better to think about age as the main time variable of interest, that relapsing remitting MS is a youthful expression of the disease, and secondary progressive and primary progressive MS are actually reflections of an aging form of multiple sclerosis. So as a big picture overview, MS across the lifespan, as I'll show you in the next slide, pediatric MS is almost exclusively relapsing remitting, and they have very high relapse rates, very inflammatory with those youthful immune systems. Reproductive lifespan milestones are also important for disease expression, including puberty, pregnancy, male hypogonadism, perimenopause, all influence MS risk and phenotype. And aging of the immune and nervous systems may be key to understanding both phenotype and pathophysiology of progressive MS. So let's think a little bit about multiple sclerosis in youth. There's virtually no primary progressive MS in kids. In the literature, it's reported as about 1% or 0.08% of kids have primary progressive MS. But as a clinician doing this for now well over 10 to 15 years, I've never seen a convincing case of primary progressive MS in children. When they've been referred to me in wheelchairs, it was often just because they were having back-to-back relapses and they weren't getting high efficacy treatment. Kids also have higher annualized relapse rates than adults. So Mark Gorman in Boston over a decade ago showed that in their children cohort in Boston, at Boston Children's, they had a 1.1 annualized relapse rate compared to 0.4 in the adult cohort from Boston. In recent clinical trials, the differences in children and adults have been even greater. The baseline data for the first completed clinical trial in relapsing remitting MS was 2 relapses per year in the children versus 0.4 in the placebo arms of recent adult clinical trials. In a sub-analysis of fingolimod trials done by Judah Gartner in the last few years, they looked at the placebo rate of relapses, placebo arm rate of relapses in recent clinical trials. And for 18 to 20-year-olds, the annualized relapse rates were about 0.7, 0.6, and in 20 to 30-year-olds, about 0.6, 0.5, compared to the rest of the population in those trials, which was the typical for adults, 0.4, 0.33. So if you look at my simplistic bar plot on the right-hand side, you can see this almost linear effect across these age groups in annualized relapse rate. So when you're young, you have a lot of relapses. Now, this question has been asked in multiple databases around the world, and age is, again, one of the strongest factors that dictates relapse rate. This is from MSBase, which is a European and Australian database of MS patients. On the y-axis is annualized relapse rate, how many relapses on average per year, and on the x-axis is age. The females are in yellow and the males are in green, and what you can see is that across the lifespan, until you get to the postmenopausal phase, females have higher relapse rates than males, and that there's this clear, almost linear drop-off in relapse rate with chronological age. So the British Columbia group also asked this question and did a very nice analysis trying to tease apart the 2 time variables of chronological age and disease duration, both of which could contribute to what we see clinically in MS. So this was in over 2,500 patients with almost 12,000 MS relapse captured, and all before 2003. So this is essentially a natural history study. The only drugs we had at that time were low efficacy medications. And what they found is overall in all these patients, there's a 17% decrease in relapse rate for every 5 years of disease duration. So in everyone with MS, their highest relapse rate is at the beginning of the disease. This is why it's so important to treat early, because relapse rate is going to drop off naturally over time. If you're a graph person, you're going to look at the bottom left. If you're a table person, look at the bottom right. This is looking at drop off in relapse rate over time. So on the y-axis, the negative direction is a decrease in the percent of relapse rate over time. And then for every 5-year interval of disease duration, but it's divided into 4 groups. Those who had MS onset under the age of 20, 20 to 30, 30 to 40, and over 40. And what you can see is for everyone, relapse rate drops off over time, but the slope is much steeper in the far right for those who are over 40 years of age. And there's much less drop off immediately in the young folks. So if you look at the table on the right-hand side, the top row, for those under 20 at onset, the relapse rate only drops off about 7% in the first 5 years of disease duration. But in those over 40, it drops off 30% in those first 5 years. Disability accumulation is also a function of chronological age in multiple sclerosis. The older you are at the time of onset, the shorter the time to disability, even independent of disease duration. So age is more important than other time variables when looking at disability accumulation as well. If you are one of our pediatric MS patients and your MS starts around age 10, secondary progression may not occur for 20 to 30 years. It won't happen in childhood, but those individuals are at risk once they enter adulthood. But if your MS starts at 40, 45 years of age, disability in terms of ambulatory function can start occurring within 5 to 10 years. And again, keep in mind that the mean age of onset for both forms of progressive disease is around 45 years, which is on average 15 to 20 years later than for relapsing remitting MS. So is biological aging, both natural aging that we and our patients face, as well as potentially accelerated aging from that inflammatory burden of MS, are these drivers of having the progressive neurodegenerative form of MS. And this very simplistic cartoon from Timmons et al. Shows this concept. If we can manipulate the aging trajectory, if we could slow the aging trajectory, can we avoid diseases of aging, including progressive MS? And for those who are having stressors or have more genetic predisposition to rapid aging, are they the ones at most risk for early and more severe neurodegeneration and progressive disease? And the corollary of this on the bottom of this slide is the geroscience hypothesis that if we are able to reverse aging processes, can we ameliorate diseases of aging, including progressive MS? So the good news is that biological age is a concept in which birth date isn't everything, that your rate of physical aging may not perfectly correlate with the number of birthdays you've happened to celebrate. And studies done in large populations around the world tell us that for a large group of, say, 38-year-olds, as done in the Dunedin study, that their biological age could range from 25 to 60. And that difference could be meaningful in looking at disease expression in multiple sclerosis. Many factors could be contributing to this variability in biological versus chronological age, including genetics. We all know those families that seem to age very well. Level of exercise, which is one of the best fountains of youth that we have. Toxins like smoking can accelerate biological age. And there are other environmental and forms of biological stress that could be impacting these processes. Biological age is relevant for the prediction of mortality and chronic diseases like heart disease. And we can have both the concept of somatic biological age as well as reproductive biological age. And in this simplistic cartoon, we largely divide lifespan into early life, midlife, later life for simplicity. And in the middle of the slide here, this concept of, is someone at a normal pace of aging where their biological equals their chronological age? Are they in accelerated aging? And these processes impact all the organ systems in the body. And in particular, they do impact the brain. And for multiple sclerosis, we want to think about our therapeutic approach in these different age groups. So we've now come to learn, and the pediatric MS population has certainly taught us that we can and should be pretty aggressive with immune suppression in those young forms of MS with high inflammatory disease and relapse rates. And as people age with MS, there is a desire to lessen systemic immune suppression due to increased complications with infections. And maybe we should be shifting our therapeutic targets to age reversal and targeting an aging immune system instead of using the same drugs and same approach we do in youthful MS. And then in the middle, this might be where it's the most important to think about measuring biological age. Is someone who's 45 biologically 45, 60, or 30? It could make a difference in how we select disease-modifying therapy. So let's talk a little bit about how we can measure somatic aging in men and women with MS. So the ultimate biological clock, or one of the most well-recognized biomarkers of biological age, is telomeres. As a reminder, these are those caps of proteins and nucleotides that protect the ends of our chromosomes. They shorten with each cell division and have been a good reporter of biological age in human disease. Telomere shortening, in addition to cell replication, can be accelerated by oxidative stress and DNA damage. And having shortened telomeres has been associated with diseases of aging, including cardiovascular disease, dementia, autoimmune diseases that have a second peak after 50, like lupus and rheumatoid arthritis. And in one study prior to ours, there was a pilot study showing that primary progressive MS had shorter telomeres than controls in relapsing disease. So we did a study collaborating with the Liz Blackburn Telomere Core Lab and also working with Jorge Oxenberg to measure leukocyte telomere length in people with MS and see if it's associated with clinical disability, brain volume, measures of progressive disease, and to see if it was associated even independent of chronological age and disease duration. We did this by measuring leukocyte telomere length with a quantitative PCR, telomere to somatic DNA ratio. And we took data from patients who had already participated in a 10-year cohort where we had 10 years of longitudinal data. Couple notes about measuring leukocyte telomere length. This is obviously an easy measure to get from the blood, a peripheral measure. And it's an accessible biomarker, though, of other cell types in the body. It's very difficult to get a hold of brain tissue throughout the lifespan in MS, but leukocyte telomere length does correlate with telomere length in other cells throughout the body. There are different ways to measure telomeres. there's a terminal restriction fragmentation assay that can be used and is helpful in comparing across studies, but tends to overestimate leukocyte telomere length. Real-time qPCR, which is what we used and provides a telomere to somatic DNA ratio, requires less DNA sample, but we did have to be very careful with cleaning the DNA. So a cartoon of our model is on the right-hand side, that both cell replication as well as DNA damage, oxidative stress, perhaps even accelerated by the MS inflammatory process itself, in addition to genetic predisposition, can lead to telomere attrition. It only takes 4 to 5 telomeres to shorten in a cell to drive the DNA damage response, downstream senescence pathways, and we hypothesize this is associated with accumulation of disability in MS. So this is from our paper from Annals of Neurology in 2019. We looked at over 500 individuals with MS who'd been followed over 10 years. Their mean age was perfect for a study of aging. Mean age was in middle age, around 43 years. And at the bottom of the slide, you can see the average leukocyte telomere length at baseline was around 1 or 0.97. And this is what we would have expected for this age range and age group. And these patients were largely captured early in disease with the low EDSS score, which is a disability score in MS on the bottom row. So just to introduce the design before I show you the results. So we did an overall cohort study where we looked at all 500 individuals in the cohort who had MS or very high risk CIS. And we looked at telomeres and their association with clinical and radiologic outcomes. The second part of the study was what's called a nested case control. So within that cohort, we looked at 23 individuals who converted to progressive MS over that 10 years of follow-up, and compared them to 23 individuals who stayed relapsing, and we matched them at baseline on age, sex, disease duration, and disability score. So here's the primary results from this study, and I'm highlighting fellow at the time was Kristen Crisco, who did some of this analysis. She's now an assistant professor at University of Toronto. And the statistically significant results are in bold. On the first row, and perhaps one of the most important results, was that disability score, an exam-based disability score for MS, was clinically and statistically significantly associated with having a lower telomere length. So having one standard deviation shorter telomere was associated in the adjusted model on the right-hand side of the table with a 0.3 higher disability score, which is clinically relevant for us in MS in a study like this, and it was highly statistically significant. Also in bold were significant results for total brain volume and total white matter volume. So we wanted to understand, we did very conservative models where we adjusted away potentially other effects from chronological age, and we also adjusted away effects of disease duration. But we wanted to understand how much of the chronological age effect could be explained by telomere length. And to do that, you do a mediation model. And the 3 steps of a statistical mediation model are on this slide. The first bullet point is the first step. So we replicated what's been shown in other studies, that for every 10-year increase in age, the disability score was 0.51 units higher, highly statistically significant. The second step of a mediation model is to look at the direct effect of age not mediated by telomere length by adjusting away the effect of telomere length. That dropped the 0.51 estimate from the first bullet point down to 0.43. And so we knew the direct effect of age that does not go through a pathway mediated by leukocyte telomere length. And then the third step of this mediation model is then to calculate the indirect effect of age that is mediated through leukocyte telomere length. We also call this the percent explained, and that was 15.1%. So 15.1% of the effect of chronological age on disability could be explained by leukocyte telomere length. So what about that nested case control that I mentioned? In a longitudinal analysis of a subset of 23 pairs, where one half of the pair went on to progressive disease, the other stayed relapsing, we examined leukocyte telomere length. So you'll notice we dropped in sample size and in statistical power from over 500 individuals down to 46. But despite that, if you look in the top row, we still had a clinically and statistically significant association of a drop in telomere length with an increase in MS disability. So having telomere shortening by 1 standard deviation was associated with a 0.3 higher disability score in these patients. We did lose some statistical power with the sample size, but some of these coefficients for the MRI outcomes were clinically relevant. They just didn't reach nominal statistical significance. So in summary, for telomere length and MS from our work, telomere attrition explains about 15% of the variance of the effect of chronological age on disability. Shorter telomere length, independent of disease duration and chronological age, so in a very conservative statistical model, is strongly associated with having higher clinical disability in MS and with brain volume. Aging-related processes are likely contributing to MS progression. Oxidative stress, decline in remyelination capacity, altered immune function are all also reported in multiple sclerosis with progressive forms. And comorbidities and lifestyle factors are likely also contributing. If an individual has an older biological age, they're not only at risk for progressive MS, but they're also at risk for cardiovascular disease. And those aspects of this need to be evaluated as well. But targeting aging-related processes may be a key therapeutic strategy to finally getting a high-efficacy medication for progressive MS. So it's always good to place your work in the context of others and see that your work is replicated. So wanted to mention these other papers. Prior to ours, Guan et al. In 2015 showed that primary progressive MS patients have short leukocyte telomeres compared to controls in relapsing disease. Habib et al., about a year after our study was published in 2020, that shorter leukocyte telomere length was seen in progressive MS compared to relapsing MS. They also showed some age acceleration, that leukocyte telomere length was shorter in MS participants versus controls, implying that in addition to normal aging, people with MS may be facing accelerated aging from the burden of their inflammatory disease. Hecker et al. In 2021 studied 40 relapsing and 20 primary progressive MS patients and showed higher risk for conversion to secondary progressive MS over 10 years in relapsing patients with lower leukocyte telomere length at baseline. So let's take a look at this cartoon we created for a review article in MSARD in 2021. The hypothesis is in the youthful state, you have full-length telomeres. You tend to have a very low burden of senescent cells, and we hypothesize less disability in multiple sclerosis. Telomeres begin to shorten with every event of cell replication, including those cell replication events that happen in MS relapses. And once you have just 4 to 5 telomeres that shorten in a cell, you can initiate the DNA damage response and cellular senescence pathways, and you begin to accumulate these senescent cells in the immune compartment and in the CNS compartment. And while these are not replicatively active, so senescent B cells, T cells, CNS cells are not replicatively active, but they can be very metabolically active, and they put out pro-inflammatory cytokines that drive chronic inflammation. And you may have heard of the term inflammaging. That's largely generated by these senescent cells. And in the chronic senescent state, you have a high burden of these senescent cells that are putting out this low-grade level of inflammation that's not responsive to MS medications, and it's not responsive to the regulatory response. And we hypothesize that this is part of the pathology driving progressive MS. So what do we know about senescent cells in multiple sclerosis? Well, over 15 years ago, Thewison et al. Put out a pair of papers that showed premature immunosenescent CD4 positive, CD28 negative T cells in MS patients that was at a level comparable to elderly participants. So these were young and middle-aged adults who had burden of senescent T cells similar to elderly healthy individuals. In that same set of papers, they also demonstrated a population of senescent B cells in MS patients that was excessive compared to controls. We know that oligodendrocyte progenitor cell senescence is part of what inhibits remyelination and repair in MS. And aged microglia, resident CNS cells, they have decreased phagocytic function, which is actually quite critical to clean up after an attack of multiple sclerosis. They have decreased chemotaxis, and like other senescent cells, they put out pro-inflammatory cytokines. And these aged microglia are very attractive potential targets for treating progressive MS. And in a very nice new study within the last year, Tika Benveniste from UAB has described an aged phenotype of neutrophils. SOC3 deficient neutrophils have very high levels of the pro-inflammatory marker IL-6. They infiltrate the cerebellum in a mouse model that recapitulates some of the severe ataxia we see in progressive disease. So there are many age-associated changes in immune function. It's not limited to just those living with MS, of course, in all individuals. And I don't want you to have to digest everything in this complicated figure. But if you look in the top left in T cells, we know there's a decrease in naive T cells, an increase in memory T cells. There's a decrease in TCR diversity. In the bottom middle in B cells, there's also a decline in naive B cells and an increase in what we think are more pathologic in MS memory B cells. So all of these changes across all of these cell types are likely relevant in impacting what we see in clinical expression in progressive MS. But the good news is, if we come back to this aging model, that there may be an opportunity to stop these processes and stop the metabolic activity or remove these senescent cells. And this may be an attractive target and an attractive therapeutic strategy in progressive disease. So this brings up the topic of a general class of activity that's being studied across medicine in both healthy aging adults and diseased adults, xenotherapeutics. And to put out some definitions here, a xenomorphic xenotherapeutic is targeting the metabolic behavior of those senescent cells, not removing them, but changing their pro-inflammatory secretion, and to try to neutralize or antagonize what's been labeled the senescence-associated secretory phenotype. Senolytics, on the other hand, target removing the senescent cells, and I'll give you some examples of those in a moment. These types of agents could be small molecule drugs, cell-based therapies, but lifestyle could also be considered xenotherapeutic. So exercise, the best fountain of youth we have, caloric restriction, and reducing other stressors may serve as xenotherapeutics in our patients. So this was a nice review put out in September 2021. And again, I'll just highlight a few things for you. If you start in panel A, which is at about 7 o'clock on this figure, some of these might look familiar to you. Rapamycin, an mTOR inhibitor, is being studied as a xenotherapeutic with potential even in MS to increase the regenerative capacity of hematopoietic stem cells and decrease senescent stem cells. In panel B, you'll see a very popular xenotherapeutic, metformin, highlighted, which might improve oligodendrocyte progenitor cell differentiation, maturation, and support better remyelination and repair. But niacin is also on this list, some other drugs that we'll talk about in a couple of slides that could impact or actually even remove senescent cells. And then panel C and D, you'll also see some concepts that you might have come across before about impacting T cell senescence, improving thymopoiesis, decreasing autoreactive T cells by targeting these xenotherapeutic pathways. And coming back to this very popular xenomorphic agent, we have several trials already ongoing in MS for metformin. And again, I don't want you to try to digest every single molecule and an element in these pathways, but metformin can act through many pathways and cells to promote a more youthful state. And I put arrows at the bottom of the slide to highlight the two concepts we've already reviewed in this talk, which is metformin might impact telomere attrition as well as cellular senescence, but also all these other pathways, including targeting stem cell exhaustion and epigenetic alterations as well. So let's give you a few examples of where we could head in multiple sclerosis by applying things that have been done in other disease states for senolytic therapies. So the approach to senolytic, to removing senescent cells, is to exploit unique features of these senescent cells to get rid of them, so that you can get rid of the senescent cells without getting rid of healthy cells. So one of these approaches is a cytotoxic chimeric antigen receptor, or CAR T cell approach, has been used to remove senescent cells in animals. And vaccines have also been developed against senescence epitopes. So I've highlighted here with the red circle at the bottom that senescent cells have unique surface markers and receptors that can be manipulated by these CAR T and vaccines to get rid of the senescent cells. Another approach highlighted with the red circle in the top right part of the cartoon on the right-hand side is to target with anti-apoptotic pathways. And this is how senescent cells avoid cell death. So we can try to trick the senescent cells into going ahead and undergoing apoptosis. So one example of this that could be promising is dasatinib and quercetin target multiple aspects of this anti-apoptotic pathway. And in diabetic kidney disease, it reduced senescent cells within 11 days. In idiopathic pulmonary fibrosis, they demonstrated clinical improvement by delivering this senolytic therapy. In systemic sclerosis, decreased senescent cell products were measured in the skin. And in Alzheimer's disease, this is also being pursued, and at least safety is looking good for this drug combination. The challenge in multiple sclerosis and applying senolytic therapies will be understanding which senescent cells are the most important for pathology and how to target them. And we need to characterize this carefully if we move this idea forward for therapeutics. So a related but slightly different concept is this data we got from a heterochromic parabiosis experiment done by Robin Franklin. This paper was published a decade ago, Rejuvenation of Regeneration in the Aging Central Nervous System. This was a really interesting experiment where they essentially sewed together the circulatory systems of young and old animals and provided young blood and young immune cells, including monocytes, to older animals. And this rejuvenated, in the mouse model, the older animals' capacity for remyelination and repair. And we might think that this is not a practical way to go in humans, but I like this picture from the TV show called Silicon Valley, where a CEO in Silicon Valley actually hired young interns to have their circulatory systems connected to rejuvenate the CEO's circulatory system and aging process. And actually, it has been done in Alzheimer's disease. So an experiment has been done to try to provide youthful factors from young donors to older individuals at risk or with early stages of Alzheimer's disease. So some interesting ethical questions, but identifying exactly what some of those factors are in youthful serum that help change the environment to promote a more youthful state in MS could be an interesting approach. But other things that could be used as xenotherapeutics include exercise and physical activity. And here's a cartoon showing all the different pathways in which exercise might be protecting telomeres. So our collaborator, Liz Blackburn, who had won the Nobel Prize, or one of the awardees for the Nobel Prize in telomeres, has been studying factors that might protect telomeres for the last 20 years. And one of the strongest is physical activity and exercise. And that's something that we can do now for our patients with MS and other neurodegenerative conditions. What about diet? Well, also from Robin Franklin's lab, Bjorn Newman was first author on a stem cell paper in 2019 that demonstrated that age-related failure to produce oligodendrocytes from OPCs could be reversed by fasting and by that fasting mimetic xenotherapeutic metformin. And aged OPCs treated with metformin regain the ability to respond to pro-differentiation signals. So both fasting and a mimetic like metformin may have potential benefit in the MS population. And currently on clinicaltrials.gov, there are 8 clinical trials ongoing looking at the impact of fasting or intermittent fasting and metformin on outcomes in multiple sclerosis. The Mediterranean diet is a little bit easier to prescribe to our patients living with a chronic illness like MS than a fasting diet. And there is literature. This is literature outside the context of MS. This is a meta-analysis. If you're not familiar with forest plots, the main thing to know in that forest plot is all those bars to the right-hand side are in a beneficial direction of protecting telomere length. So when they did this meta-analysis, it appears having a Mediterranean diet could be beneficial at preserving telomere length and having a more youthful biological age. So another hot topic in aging and multiple sclerosis is the epigenetic clock. So epigenetic clocks look at DNA methylation patterns. And as a reminder of methylation, I have the cartoon in the upper right-hand corner. So you can look at DNA methylation patterns as a marker of someone's biological age. And these can be derived and built based on lifespan, meaning how long till mortality, or health span, how long life is lived without chronic diseases of aging. And in large studies, populations, including the NHANES study in the US, these types of clocks can predict mortality and aging-related illnesses. And we've just started to see these clocks applied in multiple sclerosis. A couple of years ago, One of these epigenetic health span clocks called phenoage was shown to be accelerated in MS patients compared to controls. And there were interesting differences across different cell types, B cells, T cells, monocytes, and between sexes. Maltby et al. Just published in Neurology in 2023, a very nice study looking at another one of these health span epigenetic clocks called GrimAge in MS participants compared to controls. And this was driven largely by accelerated epigenetic age in B cells. So aging in B cells, according to these models, may be more relevant than in T cells and other cell subsets. Kular et al. In 2022 demonstrated a 3.6-year older epigenetic age in glial cells from brain tissue pathologic samples from MS patients compared to controls. And something that's very interesting is that in addition to being able to try to preserve telomere length, we might be able to reverse these patterns of epigenetic age and have an opportunity to look at whether there's clinical relevance at reversing epigenetic age. An example of this from outside the realm of MS is the TRIM study. This was a study conducted in part with one of the original inventors of epigenetic age clocks. The study was called Thymus Regeneration, Immunorestoration, and Insulin Mitigation Trial. The main factor that was delivered in this trial was recombinant human growth hormone as a xenotherapeutic, also combined with DHEA. In this case, the metformin was given to control the blood sugar response to the growth hormone, but also of interest as a xenotherapeutic if it had other independent effects. You don't need to digest all the details in these plots, but know that the negative direction on the y-axis is a reversal of accelerated aging. So in all measures of epigenetic age, there's a downward trend over 12 months after administration of this intervention to reverse age acceleration as measured by epigenetics. And now the next step in this type of work is to prove that that has clinical benefit. But some of you may be wondering, as clinicians, this is great if you can measure telomere length, if you can measure senescence in cells, but how could we measure biological age in routine clinical practice? So we've done a pilot study looking at a multi-marker index of biological age that's based on standard clinical assessments that you can do in routine practice. These multi-marker indices of biological age are thought to be more reliable even than single markers, with the idea being if you measure either resistance or susceptibility to aging across multiple organ systems, you're getting a more comprehensive look at that individual's aging response. So we use the NHANES Biological Age Index, and it includes the 10 components in this cartoon, including lung function, blood pressure, metabolic function, liver function. And here's the data from our pilot study just published in MSARD this year. On the y-axis of the box plot is the difference between biological and chronological age. The negative direction is deleterious, having an older biological than chronological age. The MS cases are in blue. The healthy controls are in green. This was 50 patients with both relapsing and progressive disease and 38 healthy controls. And as you can see in the box plots and the bullet points in the middle on the right-hand side, overall, MS patients were older than their chronological age and older than their controls. So MS patients were on average 1.4 years older than their chronological age, but we could capture extremes in both groups. There's up to a 10 to 15 year difference in both directions between biological and chronological age. So this is proof of principle that you can, with routine clinical measures, try to capture biological age. And in the last bullet point on the right, the biological age index was correlated with a walking test for MS, the timed 25-foot walk, and a cognitive test, the SDMT. So it might have clinical relevance in relationship to disability with those living with MS. And the last topic I wanted to cover was reproductive aging. So somatic aging, those processes should be similarly impacting men and women with multiple sclerosis. But what about reproductive aging? So as a reminder of sex differences in multiple sclerosis, females are more likely to have multiple sclerosis, and the overall sex ratio, at least between puberty and menopause, is 3-to-1. But males may have worse or earlier progression. Females tend to have more relapses and inflammation, at least before menopause, and sex hormones are implicated in risk and phenotype. The gender ratio before puberty and after 50 is actually 1-to-1. Pregnancy reduces disease activity in MS. Estrogens have been shown to decrease severity in mouse models, both through immune and CNS mechanisms, and low testosterone may be associated with a risk for MS in men. So we hypothesized that ovarian age may be associated with the switch to secondary progression and with disability and gray matter volume changes in women with MS. And we published this work in Neurology in 2018. Just as a reminder, the mean age of primary and secondary progressive MS is 45, very conspicuously in the time of perimenopause in women. The mean age of the last menstrual cycle is 51 in most developed countries. But keep in mind that before that last menstrual cycle, there's up to 10-year period of decline in ovarian function with lots of interesting biology that could be impacting the immune system in the brain. And we do know, looking at the overall clinical data and epidemiology, that women catch up to men in disability around this time of menopause. So does ovarian aging contribute to the development of progressive disease? To study this, we leveraged a convenient biomarker called anti-Müllerian hormone. Ironically, this is the hormone that makes a male early in development, but later in life, not relevant in males, but it's produced by the granulosa cells of follicles in women, and it lowers gradually over the course of an adult woman's lifetime. And convenient for us is it's largely independent of timing in the menstrual cycle. So much easier to measure in biobank samples than something like estrogen and FSH, which are going to fluctuate with the menstrual cycle. A level of AMH can predict 82% of the variability of the age of menopause, and it is a surrogate for ovarian reserve and fertility clinics. And what you see in the plot on the right-hand side is that over this 10-year period of perimenopause, we can separate out fast reproductive agers from slow reproductive agers in women. So it gives us this signal breadth to measure the ovarian aging process in different women. So we wanted to determine if ovarian decline as measured by AMH is associated with clinical disability or brain atrophy in women with MS. And we worked with two reproductive endocrinologists, Dr. Masurlian and Dr. Marcel Cedars. And we looked in over 400 women with MS and 180 controls. We used an ultrasensitive ELISA to measure the AMH and did appropriate statistical model. In the fourth bullet point, you see some of the confounders that we tried to examine, including whether the women were taking any hormones or birth control, if they were smokers, or if they had high BMIs. So here's a summary of our disability results from this 2018 paper. So ovarian reserve, if we look at that exponential curve on the right-hand side, just looking at a twofold drop on that exponential curve was associated with higher EDSS, which is our MS disability score, and cross-sectional analyses, and it was highly statistically significant. And as I highlight in those bullet points there, about threefold higher in magnitude than just having 1 year disease duration with MS. If we looked in a longitudinal analysis, having a twofold drop in AMH level was associated with higher EDSS score and was highly statistically significant. And this is even with a very conservative statistical adjustment for chronological X. Also consistent with our hypothesis is we found an association of anti-Müllerian hormone levels with gray matter volume in women. So again, just a modest decline of twofold lower AMH in the first row of the table was associated with cortical gray matter volume with a beta coefficient of 2.2 millimeters cubed, which is a clinically relevant difference and several fold higher than just typical aging in healthy adults, and it was statistically significant. Our results for total gray matter and total brain volume were also clinically relevant, although it wasn't statistically significant. And in the last bullet point, in the longitudinal analysis, there was also an association with twofold decrease in AMH. So what would be the mechanism of how ovarian aging is linked to MS phenotype? Well, one obvious thing would be the decline in ovarian hormone production, both estrogens and androgens. Also, keep in mind the ovary is an early marker of the aging process in general, and it's more specific than chronological age. The follicular cells in the ovary have 10 times the mitochondria, much more sensitive to environmental stress than other cells in the body. So it's like a canary in the mine, so to speak, of being able to detect aging processes. And given our interest also in somatic aging, there are associations of AMH level with telomere length in both oocytes and leukocytes. And in our cohort, AMH and leukocyte telomere length were correlated, and it highlights the need to really understand the independent effects of somatic and reproductive aging. But we did check that there are independent effects of this AMH biomarker compared to leukocyte telomere length. In a multivariable model adjusting for chronological age, disease duration, and body mass index, we observed independent effects of AMH and leukocyte telomere length. So in the statistical models, there was no attenuation of the point estimates of either of these when we put them in a model together. So we hypothesized that in women, they're taking a somatic hit and a reproductive aging hit that might be contributing to switching to progressive disease. So in conclusion, lower AMH levels are associated with greater disability, even after adjusting for chronological age, disease duration, and body mass index. Lower AMH levels are associated with lower cortical and total gray matter volumes, but they're not associated with T2 lesion volume. These results support an overall hypothesis that ovarian decline may be associated with accumulation of disability and secondary progressive MS risk. And we have seen some pilot trials completed looking at estrogen receptor agonists to counteract this effect, but estrogen may not be the only factor. And as we've learned from Alzheimer's disease, the timing of when we might introduce a hormone replacement therapy could be very important and might need to be much earlier than when we typically administer those types of therapies. So can we use testosterone in a similar way for men with MS? Testosterone declines about 1% per year in men starting in the 30s, and higher rates of decline indicate hypogonadism. We do know that hypogonadism is associated with higher risk of men getting MS as a risk factor to get the disease. Prior work at UCLA with Dr. Rhonda Voskuil and Nancy Sykott a number of years ago had indicated that low testosterone may also be associated with more brain tissue loss in men and in male animal models. And other work has shown patterns of low testosterone in men living with MS in epidemiologic type analyses. And there is an ongoing clinical trial of giving men with MS testosterone. So we have a recently completed analysis that we presented at ECTRIMS last month, looking at mean total testosterone levels in men with MS in about 146 men from that UCSF EPIC cohort that we've used for other studies. It was very low, 325 nanograms per ml. The cutoff for low T syndrome is 300. 46% of these men in this analysis met criterion for low T syndrome. And interestingly, 47% of men even under 40 years of age had low testosterone, under 300 nanograms per ml. And we didn't see differences in men with relapsing versus secondary progressive MS. And there was no correlation of total testosterone with age in men with MS. And this may be due to a floor effect, not a floor effect in measurement, but a floor effect in the sense that having low testosterone may be such a significant risk factor for men with MS to get the disease that it's not going to work as well as a biomarker of aging because they're starting off at such a low level, which is why they have MS. So I'll lastly reflect on some care consideration. How do we take care of this 46% of the population living with MS that are going to be over the age of 55? Well, one important concept is to think about the use of disease-modifying therapies. The benefit versus risk ratio shifts significantly. DMTs largely target relapses. And as I showed you at the beginning of this talk, these are naturally declining with age. And there's little efficacy or safety data of these agents in those over 55. And immunosenescence, the reason why the relapse rate may be dropping off is also increasing infectious risk. There's also a relative lymphopenia that happens with aging, and it may contribute to this risk, including more serious complications like PML. But maybe measuring biological age will be a future method to guide decisions. If we have a 60-year-old in front of us who's biologically 40, maybe that patient does need to stay on disease-modifying therapy. And if we have a 45-year-old in front of us who's biologically 60, they may be facing more risk with immune suppression. Comorbidity, as I alluded to previously, is a very important concept because as people biologically age, they're not only at risk for progressive disease, but they're also at risk for neurovascular disease, cardiovascular disease, and comorbidity may be partially mediating some of these aging effects on MS disability. This plot is from Ruth Ann Marie's work from over a decade ago, and the dotted line are patients with MS with vascular comorbidity, and the dark black line, those without vascular comorbidity. On the y-axis is the proportion without needing a cane, which drops off over time and drops off more rapidly in those with cardiovascular comorbidity. Disability from MS is also increasing sedentary behavior, which increases the risk for comorbid disease, and comorbid diseases can limit giving those immunosuppressant agents. So it's important to look at the whole individual who's aging with MS and to also consider the impact of the risk of losing social and physical support. thinking about health disparities as people age, which can be enhanced, access to primary care and being able to take care of other disease processes related to aging, and thinking about the impact of MS disability on overall health maintenance, and keeping in mind that these types of social environmental forms of stress could be accelerating the aging process and further contributing to more disability. So here's a summary cartoon about aging and MS that we published in Lancet Neurology in 2022. Starting with panel A, which we've covered in this talk, the effects of telomere attrition, peripheral immune, and resident CNS cell senescence. And below panel A, the peripheral immune effects, the senescence-associated secretory phenotype, inflammaging. And then in the middle of the cartoon, pro-inflammatory senescent microglia, poor OPC differentiation and remyelination. B, at about 7 o'clock in this figure, we didn't have time to discuss the mitochondrial effects of aging and what the hypoxic stress and energy failure from mitochondrial might be further compounding the effects of aging in MS. In the bottom middle, C, we talked about reproductive aging. In E, in the top right, we talked about the potential impact of cardiovascular, neurovascular disease, diabetes on aging-related white matter changes and atrophy that could be compounding MS. And in panel D in the bottom right, we didn't get a chance to talk about the microbiota and potential leaky gut effects with aging that could be further compounding inflammation on the gut-brain axis. And in the future, how could we target biological aging? We've talked a little about this at about 10 o'clock. How could we use antioxidants, anti-inflammatory drugs to combat cellular senescence, as well as xenotherapeutics? In the bottom middle, telomere activation, a number of those xenotherapeutics we reviewed could help protect telomere length. And then in the bottom right, epigenetic activation and being able to reverse epigenetic aging. So what can we tell our patients now about aging with MS? Well, our best tools are lifestyle modifications, including exercise and diet. We can help keep people young with these lifestyle factors, and that's something that's at our fingertips already. Having mental health and social contact can help people aging with MS, preventing and treating comorbidities. If you happen to be a diabetic, it's not a bad idea to consider metformin, given its many impacts on aging pathways. Keep in mind cancer screenings. We have some data now showing that MS may not be increasing the risk of cancer, but it does seem to delay detection of cancer. And some cancers are detected at later stages because patients are distracted with their MS care. Please evaluate the risk and benefit of giving these aging individuals immunotherapies and mitigate social, environmental, and disparity factors. And we should not wait until their age to prevent aging. We want to think about early interventions and building reserve. So in summary, the very young have highly inflammatory MS phenotypes. They don't exhibit the clinical phenomenon of progressive MS. Shorter leukocyte telomere length is associated with disability progression and multiple sclerosis and explains 15% of the effect of chronological age on MS disability. Excessive telomere attrition then leads to the DNA damage response, downstream senescence pathways that could be contributing to MS phenotype, and we see an excessive burden of peripheral immune cell senescence in people with MS. Epigenetic age can be measured in MS and is shown to be accelerated in people with MS, and it highlights the concept that people aging with MS must face natural aging as well as possible accelerated aging from that inflammatory burden. The NHANES multi-marker index is clinically accessible to practicing clinicians and can capture differences in biological and chronological age. Disease-modifying therapies, immune therapies in MS with cell depletion may be making interesting impacts on aging or impact on the measurement of aging markers. And xenotherapeutics may be a new consideration for MS research, including xenomorphic agents that change the metabolic behavior of senescent cells like metformin, or senolytic agents that target anti-apoptosis or senescence epitopes to remove senescent cells. And keep in mind, we've got fasting, diets, exercise, smoking cessation that can all help reverse biological aging, and also other forms of environmental stress mitigation may be helpful. In addition to somatic aging, reproductive aging may also contribute to MS phenotype, and I showed you data that declines in plasma anti-Müllerian hormone level as a marker of ovarian age are associated with disability progression in women, even independent of chronological age and somatic aging markers like telomere length. Comorbidities may be both a cause and an effect of progressive MS and may be related to the biological aging processes. Keep in mind the shift in benefit and risk for disease-modifying therapies, and multidisciplinary team care management could be a way to impact aging. Many people to thank in all of this work that I've presented today, both from UCSD, UCSF, the Elizabeth Blackburn Telomere Core Lab, Brown University, Dr. Maserlin, and the financial support from National MS Society, CMSC, and Race to Erase MS. So thank you very much. This is a genetic version of me, which with a much longer telomere length, and I'm happy to take a few questions. So I'll see if I can open some of the questions in the chat and take a look, as well as if anyone is able to unmute and ask some questions. Okay. So there's a question here about the plant-based diet on reducing antioxidants, medication diet. Are we recommending this? I actually do recommend, the way I phrase it is a vegetable forward diet. There are many diets being studied in multiple sclerosis, including vegetarian diets, including paleo diets, Mediterranean diet, intermittent fasting, but a common thread through many of them is the plant component and having a vegetable forward diet. I think several of these diets look promising. The intermittent fasting diet, Mediterranean diet, they each have their strengths. I think it's going to take some time to understand which might be best, but a vegetable forward diet and possibly, if they can tolerate it, intermittent fasting all look very promising. So Dr. Sinoff asks if there's a role for leukocyte telomere length measurement in clinical practice or versus the multi-marker indices. So, we've been doing this research. I'm a little biased because I feel very strongly that these are relevant measures. Leukocyte telomere length is not easy to get clinically, which is part of why we wanted to look at that multi-marker index to see if there was something more clinically accessible. We've completed a pilot study. We've got a number of other grants to try to replicate that data. If we continue to replicate the potential benefit of measuring that, and if we can complete a study that shows this measurement is relevant in both safety and efficacy of disease-modifying therapies, I think it could be relevant to measure in clinical practice, and it should be accessible to you. But as a scientist, we probably have a few more steps to try to prove the clinical utility, to prove that it could predict treatment responsiveness or safety. So we have another question about hormone replacement, about giving estrogens in menopause in patients with MS who are symptomatic. I don't think there's a concern from the MS side about giving estrogens. It's all about the safety with respect to gynecologic and breast cancer. And we're still, we're looking at agonists that might have less risk of those cancers. But I hypothesize it may not just be estrogens, that there are many biological changes happening. And if we do give estrogens, and we are trying to run an NIH much larger trial of an estrogen in MS, it might be the timing. They've learned that in Alzheimer's disease, that there's a difference if you're giving estrogen replacement in someone who's 60 versus maybe someone in the late 40s. And I think the timing of giving a hormone replacement is important. The type of estrogen might be important, and it might not all be estrogen. Okay. And the other question is, do all cells age at the same rate in a single person? I think the answer to that is no, Pavla. I think that there is already evidence in the aging work that there can be diversity. The most recent paper on epigenetic age shows the B cell aging may be important, but interestingly, that study was largely done in earlier MS, and we need to replicate that in a later stage multiple sclerosis. But most of the work that does separate out cell types shows there could be slightly different paces of aging in B cells, T cells, and myeloid lineage cells. And then also a very good question about using very highly effective immune reconstituting therapies in young people, like alemtuzumab, hematopoietic stem cell transplant, cladribine. I think it's a really good question. Having been in the pediatric MS world from the time where we were scared to use anything other than interferons to now being very aggressive, we've seen a big shift. And we know that young people can tolerate more aggressive therapies. And in fact, it's really important to change their disease course at these very young ages. It's a really interesting question. I guess my concern would just be, can we prove that the change in safety of giving someone a autologous hematopoietic stem cell transplant versus ocrelizumab, is there enough benefit and efficacy of doing that to justify the change in risk in that population? Because we're seeing great impact of just B cell depletion. It's just a whole different world running a pediatric MS clinic now. I mean, a lot of patients tell me they don't even feel they have MS, including cognitively, which is a big change from the practice in pediatric MS 15 years ago, where we were scared to give them anything and we just gave them interferons. So it's already been a big change. And I think we might need to prove that a little bit of a change in, that there's enough of a change in efficacy to justify difference in safety. Okay. So Dr. Fong, I don't know if you see other questions, but I think we addressed the ones in the chat.
Thank you so much for being with us this morning.
Happy to join you.
It looks like all the questions were covered. And again, so grateful for you to share this work with us.
Thank you very much.